Okay, so next I'd like to call up our next speaker, Dr. Asad Umar. Dr. Umar is the Chief Program Officer of the Gastrointestinal and Other Cancers Department, and he completed his PhD in biochemistry at Hopkins. So, Dr. Umar.
Thank you. First, thank you, Aki Smith and the rest of the organizing team to give me this time to talk to you guys about the advancing gastric cancer prevention as an overview from NCI. As you heard Dr. Rathmill earlier, I'm in the Division of Cancer Prevention at NCI that focuses on early detection and prevention, as well as screening of cancers. Lead the GI cancers program. Um, however, gastric, as Dr. Hayun said, the funding for gastric cancer is really low. And that's because of the rare disease or the number of cancers, as well as I think there's also really the research community have to submit um, proposals that have really good research ideas to really take it forward, as well as like screening proposals. Um, Absolutely true that in Korea and Japan, the mortality rates are way better than in the US, and screening makes the difference. It's the early detection and screening. I think it's going to be really difficult to really do a population-based screening in the U.S. because of the numbers of gastric cancer, total numbers that are for gastric cancer. But I am hopeful that actually with the new blood-based um, multi-cancer early detection tests or cancer tests that have gastric cancers also included in those, there will be actually still there's a cost issue with those as well as I mean their accuracy and all that. But I think we will overcome those issues and we'll get to that point. Um, we were actually at NCI. We're very fortunate to get funding, a bolus of funding from Biden moonshot money to actually start a set of screening trials where we are actually going to compare a number of these blood-based tests, the multi-cancer early detection tests, to actually if they are as good as they are reporting, because many of them are, I mean, actually all of them, the companies all propose that they are really good in actually detecting early or shifting the stages. We at NCI, we want to really look at head-to-head comparison of multiple tests. Which one is the best test? Which one gives you the best opportunity to really have fewest false negative and false positives as well. So let's see how this moves. So a view of gastric as well as overall carcinogenesis. Um, in the division of cancer prevention where I am, we're focused on cancer prevention, early detection, and we see that the cancer as a really you can target in the red zone where after cancer is the treatment setting, and that's the where you can have survival with cancer. What we want to focus on really is the cancer prevention, which is the blue triangle area. That's actually a larger area, and you can have multiple points in there where you can target and actually survival without cancer. And really the precancerous lesions, finding those early, and these blood-based tests maybe that we will actually get to that. I think I'm going in the wrong direction. Let's see. So cancer progression from normal to advanced invasive cancer takes really a long time, and it's like decades. So from normal to initiated to mild dysplasia, then severe dysplasia and carcinoma in situ, and then finally invasive cancer, it really gives a lot of opportunities to identify these lesions in between, as well as actually target them for intervention, actually do some prevention there as well. So we have done in some cancers have been much more successful where we have like prophylactic, like vaccines, for example, HPV, where we have a vaccine. H. pylori vaccine project was actually at one point was started. Many companies were funding it, but then it was dropped because really there's not a whole lot of um, money in for the pharmaceutical companies for making a vaccine for these, because gastric cancer actually is a huge problem worldwide. It's not a big problem in the U.S. where the money is. So that's where really the problem is. So we try to focus a lot on interception, but maybe precision screening, where a screening based on individuals' risk and those risk factors, not only just racial, ethnic, but also family history, could also make a difference, as well as now we have genetic information as well. That can also make a difference. Um, I think these numbers we all know. Incidence of stomach cancer is both by incidence is almost 1 million cases in 2022. It's the number fifth is most common cancer. Mortality is really high, almost 700,000 of those million in 2022. The risk factors are, I mean, we all know in this room, H. pylori, EBV was more recently identified when they did the genomic analysis. Smoking, as well as some genetic polymorphism in some of the genes for alcohol, for example, the alcohol dehydrogenase polymorphism has this evidence. Food preserved with salt probably uh, is more of a proxy for H. pylori, because where refrigeration is not there uh, in those countries where people really preserve food with salt, and that really is actually the proxy for H. pylori in that sense. Obesity leads to inflammation, IL-6, TNF-alpha, C-reactive protein, and insulin that all make some difference. There is some evidence, not that strong, for processed meat or grilled or charred meat for many of the GI cancers. Um, the cancer prevention, the epidemiology, as mentioned earlier, is highest in Japan and Korea and South America, as well as Eastern Europe. Adjusted rates worldwide are 15.62 per 100,000. Latin America is variable rates. It has been going down. Gastric cancer in the US, incidence has been decreasing. However, this is for overall population, but more recently in last couple of decades, in younger individuals, the gastric cancer is actually going up. So we don't really understand what's going on in terms of not only just the gastric cancer, but actually multiple other cancers. Colorectal cancer, breast cancer is also going up in younger population. Under 40, when you say younger, it used to be under 50, but now 45, as we mentioned just a little while ago, for even colonoscopy was um, dropped to 45 age, because of that increase in now 45 is the new 50. That's where we are getting there. So prevention of gastric cancer, reducing exposure to these risk factors is really is the key that I mentioned. But actually, really, secondary prevention with early detection and screening is going to make a difference. So we can't really necessarily control some of the exposure to environmental factors that we have, but screening and early detection, that we can make a difference. And then tertiary prevention by treating H. pylori EBV, vaccine strategies. H. pylori can be eradicated with antibiotics, or also treating precancers to reverse the course of disease. If we can do the screening and identify these intermediate lesions, we can target that. and reduce the actually cancer incidence. But we're not there. So I already talked about that. So there's strong data for H. pylori eradication. Number of studies. So each line here is a separate study that's showing H. pylori eradication with antibiotic treatment actually reduced. One is the line where if it's on the left side of one, the circle in the middle is the average relative risk. So generally, H. pylori eradication has the biggest benefit. Also, other cancer prevention strategies like anti-inflammatory drugs, NSAIDs, non-steroidal anti-inflammatory drugs like aspirin, is showing really a dose-dependent manner. So if you look at aspirin frequency, occasionally the relative risk is 0.96. If it is number of times is 30 plus per month, that means daily is 0.74. That means it's a 25%, 26% reduction in just by aspirin if taken daily. However, aspirin can also cause bleeding, so have to be careful in terms of use of that. There are other non-steroidal anti-inflammatories like COX-2 inhibitors also show 0.46 relative risk, much stronger benefit. These other NSAIDs also show the same pattern, so it seems like it is a real effect. And we are doing actually a number of clinical trials and looking at different cancers for NSAIDs and cancer preventive activity because they are relatively safe. There are some side effects that you have to be aware of and not take these without consultation with your doctor. The trials we are doing for cancer prevention in our at the NCI funded trials, one of them is looking at Mariva, which is a curcumin, um, uh, curry, the yellow color, curcumin is the coloring in the curry. Mariva is a nanoparticle formulation of that curcumin. Curcumin has been shown to be an anti-inflammatory, and it is really pretty safe. Um, but we have done actually a number of clinical trials with curcumin alone, have not seen any clinical benefit for colon cancer or other cancers where in animal studies they show benefit. So in humans, they didn't show benefit. We have some uh, interest in looking at this liposome nanoparticle because it seems to give more blood concentration of curcumin, so it's get absorbed better. So it's a company research is actually, I think it's available. We get that from, and doing this in Puerto Rico and Honduras, where much higher rate of gastric cancer. So we have actually fully recruited this study, 60 participants. These are small studies, but they are proof of concepts. If they show us positive signal, we can launch larger studies with the NCI community oncology program, and the cooperative groups can do further studies. Another study, very similar design, we are also working with, again, in Honduras and Puerto Rico, where there's a larger number of gastric cancer patients, is looking at difluoromethyl or DFMO. Difluoromethyl is actually was originally a chemotherapy candidate drug for treatment of cancers. It targets one of the enzymes that is important for cell proliferation, polyamine, ornithine decarboxylase. It reduces the polyamines, and ornithine decarboxylase is important. However, it didn't really pan out for treatment. Um, its side effect is a reversible hearing loss of certain frequencies, but it reverses after you stop taking it. It still is a drug for sleeping sickness, schistosomiasis in African countries. So that's actually made by pharmaceutical companies for those purposes. So it is available in our repository as for cancer preventive, and we see actually very strong signal for colorectal cancer. So we're looking at actually based on animal data that DFMO has an effect on H. pylori as well as in the gastric intestinal metaplasia to reducing uh, the, that metaplasia. Um, Again, if this is going to pan out in humans, we will find out actually pretty soon. That trial is complete, but we don't have the results from that. We also just recently funded, as a push on our part from my group, for funding more gastric cancer research, a precision cancer prevention program for gastric cancer. The project is a multi-year project where they're going to look at genomics in individuals, their genomics in the stem cells of stomach for individuals where there's a resistant clones after treatment of um, H. pylori. The H. pylori comes back, so they are going to actually target those individuals that are resistant to that H. pylori eradication with, again, specified um, interventions. That trial will be designed based on the genomic information. So that's actually is a big program project grant that's close to over 20 million over 5 years will be funded for that. So that's actually more than doubles the GI gastric funding in our program in that sense. There's also an ongoing EBV vaccine at the NCI, and as well as others are also developing it. But I think actually immuno prevention approaches or vaccine approaches, really NCI have to do it themselves, because companies are not going to do these because there's not much profit for them in that sense. So I think that's the end of my slides, and I'll be happy to answer any questions. Thank you very much. Yes.
You quoted quite a few statistics, but one that I didn't hear or I missed was, do you know what percentage of the gastric cancer patients in the U.S. are from ethnic communities or
Exact number, um, number gastric majority of cancer patients are from Hispanic background. I mean, that's why we are going actually in Puerto Rico to do the trial with the gastric cancer prevention, because we can't really find enough patients in other places. So you need to have, I mean, also in Latin American countries where there's much higher incidence, you can get those patients. So Latin American countries is where we're going, and the Latina population in the U.S. have a higher numbers as well, but I don't know exact numbers what they are. Yes, in the back.
Of people that have had H. pylori that becomes malignant into gastric cancer, I've read anywhere from 3% to 90%.
Yeah.
What is your estimate?
Yeah, so it is actually very it varies, and H. pylori is one of the microbiota, or one of the organisms that evolved with humans. And the study that were done in for H. pylori in Panama and in some of these countries, so there's like a altitude enigma where all the people have actually the same number of same percentage of H. pylori positive, but the people that live on the coast actually have a higher gastric cancer than the people that live on the mountains. And it was an enigma, and until they actually sequenced those H. pylori, so they are either from like um, your itself, like differences. I don't know if pylori really works. That I've seen in the research they have done, really videography with the fluorescence, that actually you can see H. pylori going into the cell and coming back out and go and hides there when there's a treatment is given, antibiotic treatment. So it's really fascinating, but we still fully don't really understand the differences.
I've
So
heard
yeah,
that H. pylori can actually hide
yeah,
in the gastric lining, especially, I mean,
yeah.
with endoscopy, it doesn't always, because there's not a lesion, it might be hiding. Is that
Right.
true?
Yes. So the strongest data that I've seen is with the last bullet on my final slide was that precision cancer prevention, where they actually have treated the patient, and before treating, they sequence the H. pylori. When they after treatment, uh, uh, H. pylori treatment, the H. pylori was gone, but it came back again. When they sequenced second time, it was exact same sequence. So it wasn't really even a different H. pylori. So it was hiding somewhere, and then back exactly that. Yeah.
And a colonoscopy. And in the endoscopy, they did find that I had gastritis and H. pylori. So my husband had to get tested. My kids had to get tested. We all tested positive. We went through the treatment. My husband, my oldest daughter, and I tested negative after the treatment, and my youngest tested positive again. So she just finished the second round of antibiotics. So I'm still waiting 2 more weeks because I have to wait a month to retest her. But through that time, now I'm afraid that we all got it again because we're still in the
Yeah.
same household.
Yeah, so that's the very common theme happens throughout for everyone. So that's what the last these researchers they are trying to do is actually target treatment for H. pylori based on, once they find that it's not going away, maybe there's another drug is needed there. So just add something else based on the sequence of H. pylori. So it will be targeted for each individual in that sense.
So, is this on? Yeah. So I have a question because of H. pylori. My daughter, who does not have gastric cancer, has H. pylori, but my daughter, who has gastric cancer, we don't know if she had H. pylori because she was just diagnosed with cancer. But my daughter is cured, quote unquote, from H. pylori. But now I'm wondering, like, is there some protocol? I mean, should she be tested regularly? I mean, this has me concerned. And they're not related biologically; they're adopted from Russia, Eastern European,
Yeah.
and Asian. Yeah.
Yeah, there is no, I mean, program, but I mean that's something is going to, this research that I was mentioning is going to lead to that. That maybe we need to come up with some strategy for that. Um, but I mean, the H. pylori is very common in the world. Less common in the U.S., but it is very common in Eastern European countries, in Asian countries, Latin America. It's very common. Not everyone get cancer also, so it's not necessarily. But again, is connected with this. It is a class 1 carcinogen by WHO.
Do you usually get it as a child? Because my mom just had H. pylori. My dad has gastric cancer, and when they did his endoscopy, he tested negative, but my mom tested positive for H. pylori. So I guess I have two different questions. So is it possible that he had it and at one point?
Yes. So usually people get that in their childhood, and it's like really decades. Or I mean, again, maybe nothing happens to majority of the people, but some individuals do get like pathology with that, the gastric intestinal metaplasia, and then further, that's what leads to it next steps. But we don't really know what is there another hit or something else is needed for that? We don't know that.
So is it possible that my dad had it and because he tested negative for it when he got diagnosed? But was it possible that he did have it without?
Hard to tell.
Yeah.
But usually within the family, it stays within the family. And I mean, often either it's just that it's hiding, but again, if it's not hiding, people just get like fully treated. In many of these countries we've done in Latin America, it will be the same strain that will come back when you sequence those H. pylori. They are the same one that just suggests either it was hiding or just like got again from the same family environment. You're getting it again, exactly the same one.
And because my parents live with me and I tested negative, should my children get tested for it?
Probably.
They should.
Yeah.
Is the breath test sufficient?
I'm not so sure about these tests. Actually, what is the best test? So that would be somebody else can answer that question.
So I saw one of the factors for stomach cancer you listed was the Epstein-Barr virus, and you said that is like a new finding.
Yes.
What's that mechanism exactly?
So that was actually it was new finding was when gastric cancer was sequenced in part of the Human Cancer Genome Atlas, TCGA. When NCI did that effort, they found that EBV was associated with gastric cancer as a new infectious agent. Before that, we didn't know actually EBV can cause gastric cancer. So now EBV and H. pylori by itself, like over 90% of gastric cancers are due to EBV or H. pylori. But EBV is probably easier one to to develop a vaccine. So because I think the efforts are pretty strong, it looks like actually NCI have some candidate vaccine that could be available. That EBV is the same virus that causes mononucleosis.
So should people, like, for example, my husband has gastric cancer. Should our family be tested to see if we have Epstein-Barr or H. pylori? I mean, and does that affect treatment? Whether you have that or not.
I'm not aware of any impact on treatment for that. It's more. I'm not sure what is if EBV positive would be treated differently. That probably would be a question for Dr. Marshall or Dr. Yun.
Mm-hmm, mm-hmm. But so you're saying families of the gastric patients, should we get tested for those things or not? Like to see if we've had Epstein-Barr at some point or if the H. pylori is in our system.
So I think EBV test is pretty easy. It's available to do. So that's not, I think the doctors are doing that anyway.
Well, I mean, you wouldn't have a test if you didn't have symptoms, right?
Right.
For Epstein-Barr.
Yeah.
Yeah. Okay. Just curious. Thanks.